to take this opportunity to welcome you all to the 86th session and please conduct this session. Now, I will take this opportunity to welcome our and the honored speaker paper and enlighten us with the immense knowledge he has got on this topic. Please welcome.
Dr. Rezaul Hamid is a consultant psychiatrist of Barpeta Civil Hospital. He was born at Mondia on 14/9/1977. He passed his matriculation 1993 from Mondia HS School. He passed his MBBS from Seizure Medical College on 2002. He passed his DPM from Assam Medical College, Dibrugarh on 2006 and joined at Barpeta Civil Hospital on 1st August 2006. He was the ordinary secretary of 18th Annual Conference of Indian Psychiatric Society Assam Center. Now I request Dr. Hamid for I request Dr. Jogananda Das to felicitate him by a small motion. Dr. Narayan Das to felicitate Dr. Rezaul Hamid with a Ghulam Gamusa. I request Dr. Rezaul Kori to felicitate Dr. Hamid by a memento. Thank you.
Respected President of Indian Medical Association, Barpeta Road Branch, esteemed doctors from different parts of Barpeta and Barpeta Road, esteemed senior colleagues, distinguished guests, the speaker of today's seminar, my dear brother Rezaul. All of you have know Rezaul as an upcoming psychiatrist in this part of the state. He's been able to make a mark in the psychiatric community and psychiatric society within a very short period of time, although he has done his post-graduation only 3 years back. I think during these 3 years he has done tremendous work in many ways in terms of helping people, giving services or extending services to the mental health, mentally ill patients, and also in different other activities in terms of creating awareness. From Rezaul point, and I declare that session is open, and I invite Rezaul, my brother, to take the dais. Thank you so much.
First of all, I want to express my heartiest gratitude to Dr. Jogananda for his presence out here. He has taken a lot of trouble today come work here. He had some lecture at university and finally he had come. So I am very much delighted and very much encouraged by his presence. So today I am going to talk about a few of the very basic things about seizure disorder and migraine. Simultaneously I am talking about a few of the aspects of mood disorder. Though it's not that's also relevant in this discussion. So as the molecule was already introduced by Dr. Jogananda. So before going further, let us just refresh our knowledge on seizure. As we know, seizure is a paroxysmal event due to a abnormal, excessive, hypersynchronous features from an aggregate of central nervous system neurons. Now, epilepsy is just the tendency to have recurrent seizure. we see the epidemiology of seizure. There are so many triggering factors to precipitate a seizure, and these are severe stress, hormonal changes, bright flashing lights, lack of sleep, and alcoholism. Most commonly alcohol withdrawal. 77% of the seizure are primary seizure, these are idiopathic, and 23% are symptomatic. And for this 23%, we see that 5% are cerebrovascular, then 4% CNS neoplasm, then congenital CNS malformations, trauma, CNS infection, and other known causes like metabolic and toxic. And this is most commonly encountered in our doctors of other specialty also. Then comes Bart asphyxia, which is 1%. There's a cerebral infarction due to some arterial occlusion or venous occlusion or vasculitis may also induce seizure. So there could be so many tumors. In this MRI image, we can see one glioma. And for this patient was totally seizure-free without any anticonvulsant medications after removal of the tumor. So neurocysticercosis could be another cause where it's pathophysiology. Mainly the temporal lobe and the frontal lobe are the main focus of seizure initiation. In pathophysiology, the differential knowledge is that there are two types of neurons, some are inhibitory and some are stimulatory neurons. What happens in seizure is these inhibitory neurons are less active. Then comes the role of neurotransmitter. And among all those neurotransmitters, the gamma-aminobutyric acid is GABA is the most important one. What happens in seizure is that is a decreased inhibition, GABA inhibition can result in electrical activity typical of epilepsy. So dopamine is another important neurotransmitter that is associated with seizure disorder. The neurotransmitter will activate the next neuron and this inhibiting neurotransmitter will not. So lack or excess of neurotransmitter plays a role in the genesis of an epileptic seizure. So let us just refresh these seizure types. The seizure could be partial or generalized, and the partial seizure are those whose seizure activity is restricted to a discrete area of the brain. And sometimes these partial seizures are associated with some structural abnormality of the brain. And generalized seizure, these seizures are generalized into the diffuse region of the brain, and in contrast, this generalized seizure may result from some cellular, biochemical or structural abnormalities that have more widespread distribution. Generalized seizure involves the entire cortex. So if we see the distribution of seizure disorder in pediatric group of patients, we see that 50% of the seizures are partial, 42% are generalized. Same you see in adult this distribution, and we will see that 57% are partial, 40% are generalized, and 3% are undetermined. The muscles of respiration contracts and it causes expansion of the air inside the lung and it causes the epileptic cry. This is a very classic feature with which this generalized seizure starts. So in this again there is a phase of some relaxation, and what happens, this relaxation phase goes on increasing, and within 1 minute the tonic phase passes off and patient becomes completely relaxed. So post-ictal phase, what happens in the post-ictal phase, this patient remains unresponsive. This muscular flaccidity, bladder and bowel inconvenience may occur at this time, and patient regains consciousness over a minute or hours. And within this transition, there is typically a post-ictal confusion, and subsequently the patient may complain of fatigue, muscle ache, etc. And then most widely encountered in our day-to-day practice regardless of the specialty. Patient comes with headache. This is a common misdiagnosis for migraine is simple sinus headache. Anyone having some headache thinks about the sinus headache, and then the stress headache, they say I'm having so stressed, so I'm having headache, and referring to ENT for sinus headache or some facial pain. Now, these migraines are more likely to have motion sickness. This time you should remember. And half of the venous patients they claim to have some symptoms that resembles migraine. Now, it's going to be so much the cost of therapy is a 13 billion per year. Bipolar disorder, I'm not going into the details of this topic. I'm just briefing. Is that suppose some person is in normal mood, we call it euthymia. But sometimes due to some excessive stress or some other factors, our mood could be depressed. Or sometimes with some positive reinforcement, our mood could be elevated. But it is within the limit, it fluctuates our mood. But if, we call it pathological. When this mood swing is very significant and it causes the person himself to suffer, this is number 1 point. Number 2 point, these mood swings or all these symptoms causes distress to the people surrounding him. Suppose a manic patient. So 4 or 5 people will be required to control that manic. And it will be causing a socio-occupational dysfunction for the patient. And so if he fulfills all these criteria, then we brand him as to having some mood disorder. And if mood fluctuates, as in this illness, it is very typical that this mood fluctuates from the mania to depression. And there is so many patterns of this mood fluctuation. Depending on this pattern, we used to classify mood, this bipolar 1, bipolar 2, schizophrenia. There are some kindling phenomena in the temporal lobe of the brain. There is the kindling phenomena, this is the subfacial electrical discharge, just like epilepsy. And so this is the rationality and this is the main point of research. Some mood disorder, we used to keep in mind so many facts, like it should be efficacious in mania, it should also be efficacious in depression, it should be well tolerated, and its safety profile should be high. Now we are coming to the main, it's magnesium vampire. There is mode of action, and we are going over these 4 basic mechanisms, the action on the sodium channel, then the GABA receptor system, then the glutamate, and by calcium. So it causes decrease in seizure activity and seizure propagation. So let's come to its mode of action. It's a very brief pharmacokinetics of medicine backward. Its oral bioavailability is 70 to 100%. It takes peak by 1 to 4 hours. Its volume of distribution is 0.13 to 0.019 liter per kilogram. We can use magnesium valproate in treatment of generalized or partial form of epilepsy as first-line therapy. We can use it in treatment of mania. We can use it in prophylaxis of migraine.
Rezaul, for your excellent presentation. It is indeed a very difficult task because 3 topics at a time: seizure disorder, migraine, and also a bit of bipolar disorder. It is an extensive topic. It is indeed very difficult to put everything in a very short period of time and to send the masses slowly. But I think you have done an excellent job by covering all the factors. Now, the session is open for discussion. Any questions, please. Dr. Rezaul is ready to satisfy your queries. Please.
In the renal function, is there any cutoff like this should be the creatinine clearance above which we can give, or how we should adjust the doses like per kg body weight or per kg that you say? So we have to, what we mean, I want to know is that we have to do dose reduction. Yeah. So number 1, is there any cutoff like above this creatinine clearance we cannot give, or below this we should give this much? Like, how do we adjust the dose?
It's a very important question. And the sodium valproate is mainly metabolized by conjugation in the liver.
See, in our practice, when we start treat, first we get good response also. After few months, I used to see that it is not responding. Again, it is frequency coming. Epileptic seizure.
Right. It's very important.
Maybe after 1 or 2 years, he fails to provide response. I do not think, from molecular point of view, it has got any resistance. What probably, in my practical experiences, I can tell you one thing. Many patients, after a period of time, they do not comply the medication. In one slide you have shown failure and success of an epileptic. But I think all of who are experienced in treating epilepsies in our community.
Most of the doctors are confusing this issue. I don't know whether I will be able to clear this confusion, but I will try. It's a very debatable issue when to start treatment for epilepsies. First of all, if the patient may have seizure, suppose the patient with alcohol withdrawal, he may have seizure. But usually what you see that if we control that seizure, we control this withdrawal part, then he no more develop seizure later. And we used to get confused, suppose in case of cerebral stroke, head injury or something like that. But we see that the stroke patient may not develop seizure for 2 or 3 months. He or she may develop seizure after 2 or 3 months. Now, first of all, we are sure that this is seizure. This is not pseudo seizure or something else. Then we should instantly start. As there is a recurrence, as you have diagnosed this epilepsy, we call it epilepsy when it is recurrence, tendency to have repeated seizure. Then we will be starting the anti-epileptic drug. Then we will be starting. There are so many options. We have to take into account so many factors. There are so many triggering factors like lack of sleep may also induce seizure. We will start. No, some stress, flickering of lights, so many factors. So if the patient can seizure, we investigate. And we will start treatment when it is epilepsy. Right.
But many times you may not find findings in easy also.
No, so one of the cases we are not finding anything. I have told you that we were delighted by the presence of Dr. Zandadas. And it's very well known that he is the only person who can answer so many issues, confused issues of not only of medical fraternity but also of laymen. And he has been doing from such a long time. And I would like to take few more time from Dr. Zandadas, and I will be asking the audience to ask some questions. Actually, we should take this opportunity to know so many facts from him. Please ask Dr. Zandadas.
He is putting a ball in my court now. It's very clever.
Febrile convulsion, repeated febrile convulsion.
Baby, young children.
Whether it may turn to epileptic.
As the history goes, as the story goes, repeated febrile convulsion not necessarily lead a person to a primary epilepsy. Not necessarily. It is always real, and that is why it is known as a febrile convulsion. He has got convulsion when there is a fever. If he has a fever, you inject or give diazepam syrup or whatever it may be. Not necessarily a child with febrile convulsion will turn into a case of primary epilepsy. Not necessarily. But he or she can. When he or she grows up, he or she can have continue to have epilepsy even without fever. In that case, we have to label it not as a febrile convulsion. Now, the whole diagnosis classification. And I am very, very thankful that we had a very wonderful session and wonderful interactions also. Very rarely in seminar like this, we tend to involve ourselves in such a healthy and positive way with a lot of involvement. I'm really very happy to be here. Finally, once again, I'd like to thank IMA Barpeta Road branch, and I'd like to congratulate once again each and every member of this branch. And I do feel and I hope the good work that has been continuing by IMA branch will continue in the much better and bigger dimensions in the years to come. And I also promise that in future, if you invite me again, I'll be really, really helpful. I'm happy to be here with you. Thank you, all of you. Thank you so much. I now hand over mic to our president.
Dr. জয়ন্তদাসের পিছত আসলে কিবা আমার দেউয়ে যে পূজার উপর যে আধুনিক দিয়ে এই আধুনিক দিয়াদের লাগি এনিওয়ে এই আবার সান সম্বাসিক বাংলা আছে দেখে থাকবো এই কোনে কত আপনার বিয়াত্মক করি
Just I have to say that we are very much thankful that we got the chance to sponsor this program, and I on behalf of Sanalis and Farmer thankful to Dr. Rezaul sir that he has taken the session, and also thankful to Dr. Rezaul also that he came from a long way to attend this meeting. With this, and thanks to all of you for attending this meeting.
Thank you. Conclusion by President. More details follow up, right? আজি আমার যে সেমিনারের যে সাবজেক্ট আছে মই একটু সাবজেক্ট পড়ি হই ভাবিছো যে আমি তো কি করিম তো দেখিলো যে নহয় এগুলা আমার এই যে সেইটুকু যদি আসলে হুকাল পূজার উপর ওলাই ঠিক তেনেকুৱা এটা মোৰ ভাৱ হ'ল যে আমিও কিছু বুজি পালো এই তেলবোৰ এইবিলাক আমি কেতিয়াও ইউজ কৰা নাই এইবিলাক কি এসময়ত কি কৰিছিলো যেতিয়া সাইকাট্ৰিষ্ট বিলাক আছিল এতিয়া কৈছে যে এই সময়ত মই নোৱাৰিলো মোৰ পুৰা জয়ন্ত মোৰ ভজাৰিলো আৰু আমাৰ ডক্টৰ জালিদৰ মানে খুব বন্ধু জালিদে 10:30 বজাতো আহি ওলাই আহি গলাগলি কৰিছে গতিকে মই মোৰ প্ৰেচিডেন্সৰ লেকচাৰ একো নাই গতিকে সকলোকে ধন্যবাদ দিছোঁ ইমান গৰমত ইমান দেৰি আহি আৰম্ভ কৰিলোঁ ধন্যবাদ ৰেজাউল
Hello.